overview. Now we'll hear Dr. Veena Viswam from Amradeep Eye Hospital, Trivandrum, talking to us about traumatic glaucomas and how to medically manage them.
Good evening, everyone. First of all, I thank Dr. Kiran for giving me this opportunity. That was an intensive talk by Mini Madam and regarding the overview of blunt trauma and IOP rise in surgeries. Now, I will be dealing with glaucoma in closed globe injuries, evaluation and medical management. So when Kiran asked me to present this, I was thinking how we clinically see such patients and how we approach such cases with blunt trauma, and how as glaucoma consultants we approach a blunt ocular trauma. So
who is covering the eye? Perhaps it's just above.
all of us sitting here might have seen one or two cases with shuttlecock injuries or ball hitting the eye, children brought to us in the OPD. And we know that the blunt ocular trauma, it directly causes an anteroposterior compression to the eyeball, and when the equatorial diameter increases and stretches the ocular cords, almost all structures in the eye are affected, like the angle, the lens, the retina, the ocular cords may get damaged, the optic nerve may be damaged, and even orbital fractures may. When we see, these are some of the causes we usually see in sports injuries, very common, then occupational injuries, road traffic accidents. Such cases are usually brought to us in the OPD, and sometimes even we see our favorite sports persons getting injured in the field. And as a consultant, what all should come to our mind when we are seeing such a patient? First, important things like globe rupture, traumatic optic neuropathy, retinal detachment, orbital fractures, emergencies should be ruled out. And then always we should keep in mind the chance of developing glaucoma in these patients as well. So as glaucoma consultants, what all things can usually give rise to a raised intraocular pressure in the blunt traumatized eye? Usually, traumatic iritis is very common. Hyphema is another important cause of raised intraocular pressure in these eyes. Angle recession can cause raised intraocular pressure. Then lens dislocation, though it is not as common as the other causes, this is also an important factor we should be kept in mind. And in vitreous patients who have had vitreous hemorrhage, a chance of gauze cell glaucoma. Other causes like phacolytic glaucoma also should be kept in mind. I'll be only dealing with the important causes which we usually see in the OPD, like this. So how do we diagnose and manage such patients? So in such patients, history gives very important clues. Usually unilateral presentation, detailed history should be taken, whether there is a history of trauma. Sometimes some infections, systemic infections like tuberculosis or some autoimmune causes can also lead to iritis, which may be mistaken for an in the past. All these should be asked to the patient. 20% of iritis is traumatic, and usually it occurs in younger population. Torchlight examination will give very important clues. From the pupil, we can see whether there is an optic nerve injury. If RAPD should be checked in all these patients. Then whether the pupil is mydriatic or miotic. Sometimes due to the nociceptive effect, the pupil will be miotic, or due to sphincter tears, the pupil may be mydriatic. There may be formation of peripheral anterior synechiae in the later stages, which can result in irregular pupil. Rule out other causes like redness, discharge, or anything is there. We have to rule out those other causes. also, and always look for some signs of photophobia, which may give you hints about the traumatic iritis cases. Then slit lamp examination, we can see circumcorneal congestion, sometimes flare, cells, hyperpion. In viral keratitis and all, if there is associated uveitis, there you can see corneal scars, scapies. So these will rule out such causes which may be confused with traumatic uveitis. Then in trauma, you can see mostly in blunt traumas, there will be Vossius ring on the lens. And in gonioscopy, we'll get very important clues like if there is an angle recession or a cyclodialysis cleft or a microhyphema, some clues about a traumatic injury can be found out. Then always record the history of the patient. In all trauma cases, history, visual acuity recording is very, very important. Pupils, intraocular pressure, and dilated fundus examination is a must. Then in mild iritis case, how do you usually treat? Usually topical cycloplegics will keep the pupil dilated and prevent Seine formation and stabilize the blood aqueous barrier and prevent further protein leakage, and it will prevent ciliary body and pupillary spasm that causes pain. And topical steroids are usually given according to the grade of uveitis. In severe uveitis, you can give more frequent drops. In mild uveitis, the dose can be lessened. Then topical beta blockers are usually the first given along with the first line of treatment of steroids. Then the patients are usually followed up every 5 to 7 days at least, and the risk of rebound iritis increases if the steroid is not tapered. Then gonioscopy and indirect ophthalmoscopy, as I have already said, should be done on every visit. Prognosis is good, and some complications like glaucoma, cataracts, cystoid macular edema, etc. should be kept in mind on every follow-up. Then in mild uveitis, always rule out a corneal aberration which may sometimes be missed. If there is mild uveitis, retinal detachment also may be associated, so look for that. Always keep in mind the chance of an endophthalmitis which may be there along with some open globe injury while examining a patient with blunt trauma. Now going to the second important cause of raised intraocular pressure in blunt trauma, hyphema. Hyphema, blunt trauma is one of the most common cause of hyphema. Clues, as I said earlier, from history, almost all these cases may have associated findings, like uveitis patient may be having hyphema, microhyphema, or angle recession. So always you have to look for all these things in all such patients. History of trauma, torchlight, I think I need not repeat all this, I have already said this. A B scan may be useful when dealing with patients with total hyphema to understand the status of the eyeball, inside of the eyeball. Sometimes if you are suspecting open globe injury in a case of hyphema, CT or MRI may also help you come to the diagnosis. In a slit lamp examination, the hyphema height should be measured so that you can see how it is regressing. Also look for other findings like iridodialysis, sphincter tears. Sometimes mostly hyphema patients, because of the extent of injury, it may be associated with with phacodonosis or iridodonosis, and a chance of rebleed should always be kept in mind while you are treating a patient with hyphema. Veena madam has already said in detail about all this. Hyphema grading is important because according to the grade of hyphema, the chance of IOP rise also increases. So the chances of the patient developing higher IOP increases according to the grade or severity of hyphema. Also, rebleeding hyphema also leads to raised IOP. The chance of raised IOP is high in rebleeding hyphemas. So we all know how to manage hyphema. Though there are different studies which give different opinions, limited activity and eye shield, keeping the head elevated position so that the hyphema settles down due to gravity, such things should be kept in mind. And antifibrinolytics has some role. systemic or topical and Tranex or alpha aminocaproic acid may help. And I'm not going to the details. It is an analog of amino acid lysine, and it inhibits plasmin, which is involved in fibrinolysis, and it prevents the normally occurring clot lysis, which usually occurs in after the 5 to 6 days, and that is what usually results in a rebleed. So in rebleeding cases, Tranex is usually found to be effective. The dose is 50 milligram per kilogram, and a maximum of 30 grams per day QID may be given. And it is usually contraindicated in active intravascular clotting, thrombosis, hemophilia, and renal failure patients. Corticosteroids, prednisolone has an important role. It stabilizes the blood aqueous barrier. Topical prednisolone has a role, but even systemic prednisolone is found to inhibit fibrinolysis. So prednisolone is also systemic. Even systemic prednisolone also helps in stabilizing the clot and preventing rebleeding. Atropine is also given to keep the pupil dilated. Then the role of conjugated estrogens like primarin, which increase prothrombin concentration and decrease antithrombin activity, is also debated, and some doctors prefer to give this as well. And it is also known to reduce secondary hemorrhage. So when do we hospitalize hyphema patients? Usually, if it is children or non-compliant patients, sometimes may require hospitalization. Patients with bleeding diastasis or blood dyscrasias are usually hospitalized. Patients with severe ocular or orbital injuries, we know that needs hospitalization, and patients with concomitant IOP elevations with sickle cell disease also needs hospitalization. Aspirin and NSAIDs can increase the risk for further bleeding, and so such medicines are avoided, and for pain relief, indomethacin or such medicines are usually given. Surgical treatment in sickle cell disease, if the IOP is more than 24, and if the non-sickling cases, if the IOP is 60 for more than 2 days, and if the IOP is more than 25 with total hyphema for at least 5 days, and if the cornea is getting stained with hyphema, or if the hyphema is failing to resolve to less than 50% for 8 days, we may go in for a surgical removal. But it depends upon the treating surgeon how to follow up this patients. And in clotting disorders, we give an infusion of the deficient clotting factors for the first 5 to 6 days, and always keep in mind in children the chance of amblyopia. In children also, alpha aminocaproic acid and systemic steroids are given. In sickle cell disease, there is an increased risk of hemorrhage, and there is a high risk of developing high intraocular pressure, optic atrophy, secondary hemorrhage, and even central retinal artery occlusion. Timolol, brimonidine, dorzolamide, methazolamide, topical dorzolamide. Dorzolamide is not usually orally given. Topical dorzolamide can be given after giving timolol and brimonidine if the IOP is not getting controlled. Topical dorzolamide can be given. Then methazolamide can be given, and usually hyperosmotic agents like mannitol and glycerin are usually, oral glycerin are usually avoided because it may lead to hemoconcentration in sickle cell patients. Systemic carbonic anhydrase inhibitors can lead to systemic acidosis, and avoided in sickle cell patients. Now coming to angle recession, 60% of eyes with blunt trauma will develop angle recession, some degree of angle recession, and a small percentage may develop of such patients will develop glaucomatous optic neuropathy and vision loss even months or even days or months or years later. In gonioscopy, we know that in angle recession there will be asymmetry of the angle recess, widening of the ciliary body band, retro displacement of the iris root, irregular or darker pigmentation in the angle, whitening of the scleral spur due to visibly fractured iris processes, and associated peripheral anterior synechiae, iridodialysis or cyclodialysis also may be present. So, cyclodialysis cleft should always be kept in mind while we are dealing with an angle recession patient, because the IOP will be low at presentation. Even if the patient is having an angle recession, the IOP may be low, and we may, but these cyclodialysis clefts may close by themselves after a few weeks or days, and later the pressure in the eye may rise, resulting in high intraocular pressure. So these patients should be followed up, usually the cyclodialysis cleft patients will also have increased pigmentation of the angle and wider angles, and if the angle recession is more than 180 degrees, it is a significant factor to develop glaucoma. UBM plays a very important role in identifying angle recession patients. Long-term scarring and fibrosis of trabecular meshwork or Schlemm's canal and elevated pressure can occur over the years, and difficulty to control medically and surgically. Counseling and regular follow-up is very important in angle recession patients. Treatment is topical aqueous suppressants. Prostaglandin analogs are usually avoided in the acute phase, and later as it bypasses the dysfunctional trabecular meshwork and increases the uvascular outflow, it can be used in the later phases. And pilocarpine is reported to exacerbate angle recession. Now coming to lens dislocation, Mini Madam has already told you the ways by which lens dislocation can cause raised intraocular pressure. Anterior dislocation can result in pupillary block and raised intraocular pressure. Posterior dislocation can result in prolapse of the vitreous into the anterior chamber and result in pupillary block. So anterior subluxation should be checked. Inflammation associated with dislocated lens can cause IOP rise. Vacuolitic glaucoma or obstruction of trabecular meshwork by vitreous prolapse or chronic angle closure from peripheral anterior synechiae, all these can cause IOP rise in these patients. UBM also sometimes give clues regarding this. We had a case, 84-year-old patient with history of fall, actually a pseudophakic patient. She came back to us with pain and intraocular pressure of 60, and I could not show you the vitreous in the anterior chamber clearly. That's why I have just marked. That was a pupillary block due to the vitreous coming into the anterior chamber and filling the anterior chamber through the pupil. So the patient had severe pain and pupillary block, and the pressure was 60. And this was because the posteriorly dislocated lens had come forward when she was sitting, and sitting in her sitting position. The lens came forward and blocked the pupil, and when the vitreous also came into the anterior chamber, the pupillary block was there. And this patient, we did a PI, and her intraocular pressure came back to normal. There is in the literature, there is a sign called the floating lens sign. That is, when the lens is dislocated, it can go and fall back. In the axial CT, we can see in the supine position that the lens will be falling back and will be falling at the back side of the globe. When the patient is asked to hyperextend the neck, and when a coronal CT part of the globe, and we can see the position of the lens in CT scans. So treatment, as I told you, mannitol, acetazolamide, cycloplegics, supine position, and PI. Supine position will cause the lens to fall back and the pupillary block to get relieved. So such patients due to lens dislocation needs lens removal if the pressure is rising, and if there is a lens-induced acute angle closure due to pupillary block, persistent uveitis, or lens corneal decompensation. Now the last one is ghost cell glaucoma. It is usually a clinical diagnosis. Clues are IOP spikes and vitreous hemorrhage 1 to 3 months prior to presentation. IOP may be markedly elevated with corneal edema, and ghost cells may be there in the anterior chamber. Disrupted anterior hyaloid phase. Gonioscopy will show open angles and ghost cells layering the inferior angle due to gravity. Fine layer of khaki colored cells may discolor the trabecular meshwork. Pseudo-hypopyon and appearance of old hemorrhage, khaki coloration of RBCs and clumps of extracellular pigmentation from degenerated hemoglobin and hemin vitreous. Candy striped appearance, as you all know, may also be there in the anterior chamber. Usually it resolves once the vitreous hemorrhage has cleared, and aqueous suppressants and oral and carbonic anhydrase inhibitors can be added. IV mannitol or Diamox may have a role. Prognosis is excellent, and uncontrolled IOP may lead to optic nerve damage, but once the supply of ghost cells is exhausted, it will cease to accumulate in the anterior chamber. Now watch out for signs like sequelae. Any sequelae can be there, like I told you, peripheral anterior synechiae formation, or ankle recession, getting cyclodialysis cleft, changing to raised intraocular pressure. Such sequelae should be watched for, and recurrence of bleeding into the anterior chamber or uveitis, and steroid-induced glaucoma is another factor which should always be kept in mind, because we are treating the patient with long-term steroids, and such steroids can in the long run result in raised intraocular pressure and glaucoma. So prevention also has a role. So protective helmets or protective gadgets should be worn, especially for sports people. And thank you.
Thank you, Dr. Veena, for the detailed presentation.